Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clunit, serving as the allocated session assistant to ensure a seamless experience. Clunit proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride the Clunit serves as a data partner for this event hosted by National Neonatology Forum Gujarat, and the focus of today's session is Journal Club from Evidence to Practice. Now, I would like to welcome Dr. Praful sir to proceed. Over to you, sir. Thank you so much.
Okay, thank you. Good afternoon, everyone. On behalf of NNF, I welcome all of you. And today's our series Journal Club, that is every third Wednesday of every month. Today we are going to discuss on about can we omit IV fluid on day one on in stable preterm infants. So first of all, I would like to invite Dr. Yogesh Parikh sir, who is the president of NNF Gujarat State Chapter. Sir, please welcome and give your blessings for today's session.
Thank you, dear Dr. Praful. Respected our chief guest, Dr. Bijan Sahaji, guest of honor, Dr. Sheila Iyer, Madam, our IAP Vice President of the West Zone, Dr. Sandeep Trivedi, our President-elect, Dr. Monish Shah, then our Dr. Urmi Madam, Dr. Nehal Patel Madam, our Dynamic Secretary of the AOP Gujarat and the EB colleague in the NNF, Dr. Aparna Madam, Dr. Vishal Goyal, our Treasurer, and today's President, Dr. Rasna, and all the EB colleagues and the OB members who have joined on this digital platform, and dear friends. It is our immense pleasure and pride to welcome you all for this session of the Neonatal PATHSHALA, the fourth session of the first session of the Journal Club series, and today, this month's fourth. So under the banner of the NNF Gujarat, today we are here to discuss about the academic exercise. And as Dr. Praful mentioned, today's discussion can we skip IV food on the day one in the stable preterm. And presenter Dr. Rachna Goyal is presenting on both on this timely and thought-provoking the challenges. So let us discuss about this. And Dr. Aparna Madam is here as an expert, and Dr. Bijan Shah and Dr. Sheila Iyer Madam also contribute for this. So friend, this is the strength of the NNF Gujarat, which lies in our collective commitment to structured learning. Neonatal PATHSHALA is not just a program, but it is a movement, and a movement toward the clarity, transparency, and the clinical excellence. So each session, from the focus to our ground round, journal club, and the case discussion, each session is a step forward in nurturing a culture where the practice is not dictated by habit but by the science. So I must acknowledge the tireless efforts of our NNF Gujarat Secretary Dr. Biraj uh, and Dr. Urvi Sangvi Madam, who was in charge of the project of this journal club. Their dedication ensured that every academic initiative is impactful and seamless. Together, we are building the platform that empower young minds, strengthen collaborative learning, and uphold the value of the unity and evidence practice. So, as we embark on this today's discussion, let us remember one hour of the sharp evidence can transform decades of the practice. Let us listen, question, and reflect with our open minds, for the further future of the neonatal care depends on how courageously we can adapt to new knowledge. So on behalf of NNF Gujarat, our Secretary Dr. Viraj, I welcome you all once again. So let us have a committed learning today. Thank you. Over to you, Dr. Praful.
Thank you, sir. Now, it's my immense pleasure to introduce our today's chief guest, Dr. Bijan Shah, who is a professor and head at Department of Neonatology, IPGMER, and the SSKM Hospital, Kolkata. He has a special interest in non-invasive ventilation as well as LISA, in neonatal resuscitation program as well as infection control. He had more than 60 research publication also, as well as contribution to in the several books as a author. So I welcome Dr. Bijan Shah, and sir, please give few words regarding today's event. Welcome, sir.
Thank you, Dr. Prabhu. And first of all, let me thank the organizer and the Gujarat Neonatology NNF branch for inviting me as a chief guest for this academic program. Today's discussion will be on, can we skip fluid from day one? Because we know the nutrition plays an important role in the growth and development of a neonate. Some of us know that mother's milk is the best nutrition for a newborn infant. But some of the babies who are born less than 1.5 kg or less than 1 kg, many times we start with IV fluid, intravenous fluid, maybe just 5% extra, 10% extra, or total parenteral nutrition. But if all of you who are here and will agree with me, the population what we are dealing in this country is little bit different from what is in the West. Most of the infants who are born here, maybe preterm or term, there many of these infants will be of small for gestational age infants. And if you see that in smaller infants, providing IV fluid or TPN is not an easy task. And many studies have been done in this country, and we have got enough evidence from this country that these babies, those who are born less than 1 kg or 1.5 kg, from day one we can start enteral feed. And once we start enteral feed, that means we give the total nutrition to an infant. We are giving nutrition in the form of carbohydrate, protein, fats, bioactive elements, everything is there. So although the evidences are there from our country, but there are not much evidence from the West. So today what we are going to discuss, what is the evidence, what is in the West. And the today's journal club, what has been actually selected, it is an ideal one. Because we have got some evidence from our country, but let us hear what is there in the other parts of the country. Now once our speaker starts speaking on this topic, we will be knowing that even if people have started believing that these babies can be fed from day one itself. That means keeping a baby on nutrition or feed, enteral feed from day one, it makes our life very easy. So that is what we are going to speak today, and I am sure our speaker Rashna has prepared well. She will be speaking us. I am not going to speak in details about it. Thank you very much. Thank you once again for inviting me as a chief guest. I hope this discussion will be a meaningful one. Thank you.
Thank you very much, sir. Rightly said, most of the preterms in our country are not getting the human milk. So, and for that, one of the pioneer of the this human milk bank in Baroda, who is the Dr. Sheila ma'am, who is the today's our guest of honor. And it's also my immense pleasure to introduce her on this lecture. This is regarding the feeding about the preterm baby. She is a former professor and head Department of Pediatrics, SSG Hospital. Currently, she is a professor of neonatology at Parul Institute of Medical Science and Research, Parul University. She is also a postgraduate as well as undergraduate teacher at MS University, Baroda. She is also a course coordinator for IAP Neonatology Fellowship at SSG Hospital. She is also awarded at Gujarat State NNF Oration in 2022. As I said, she established NQS certified human milk bank at SSG Hospital, through which so many preterm baby got this human milk bank and not the formula fed. She also established DIC with a newborn ROP and hearing screening program, which is running very well. Also, her interest, especially her interest in neonatology as well as in nutrition, growth and development. Also, she is a trainer for FBNC, NRP, NBSU, NSSK, KMC, and she has also experience in this academic as well as in organizing some conference. Also, she was secretary at NNF in Gujarat State Chapter in 2003-2004. She was president in Gujarat State Chapter NNF in 2011 11 to 2014. Also, ma'am was advisor for Gujarat State NNF since last 3 years, 2003 to 2025. So, ma'am, welcome and please shower your blessing for today's topic, which is your favorite regarding the feeding as far as the newborn is concerned. Welcome, ma'am.
Prapul, madam is advisor for this year also.
Uh,
She is continuing advisor.
Lifetime.
sure, ma'am. Ma'am, unmute your audio, please. Ma'am, unmute.
Good afternoon to everybody and my guests from other states also. This has been, Gujarat NNF has been our baby and we have nurtured it from the time of its inception. So any activity of Gujarat NNF is always very, very dear to me. And today's subject, definitely, as Dr. Bijan told us, that in our country, we have been more than convinced that early exclusive enteral feeding for VLBW and babies around 30 weeks and plus, and lot of evidence from our own country. But probably a larger study and coming from West also would be definitely with telling us that what we've been perceiving is being perceived by others also or not. And as Praful told, probably we have not been dreading NEC as West has been. Though we have a lot of SGA, because the human milk plays a major role. And I think all of our trials have had more of human milk, pasteurized donor human milk and mom in most of our trials which have been conducted in India. So that might have played a major role in tolerance of early tolerance of this exclusive enteral feeding. I think we have a very good feed trial one today for discussion, and I think that should take us a long way. And we could also be adding to our knowledge in this. Dr. Aparna, welcome to NNF Gujarat. Yeah.
Thank you, ma'am.
Thank you, ma'am. So, without wasting much time, I would like to invite today's project in charge, Dr. Urvi Shangvi, who is the neonatology logist at the Anmol Newborn Care, Rajkot. So, ma'am, please welcome and over to you.
Thank you, Yogesh sir. Thank you, NNF Gujarat, for giving me this responsibility of a journal club. Basically, I mean, everyone has highlighted a much, but just to brief a bit for 1 minute, journals, why they are necessary? They are critical for validity, archiving, and disseminating the new research. So the scientific knowledge becomes accessible to all and it becomes credible also. And the purpose of journal club is important because it helps in foster the critical appraisal skills. The participants or the students, even the faculties or consultants become updated with the latest research, bridge the gap between the evidence and practice. So not much wasting time, I invite our expert, Dr. C. Aparna. She is a DM neonatologist, clinical director, head NICU from KIMS, Cuddles, Kondapur, Hyderabad. Madam is editor in IPP protocols. She is coordinator of many fellowship programs, DNB programs of neonatology, has many publications. She has received a Young Achiever Award in Neonatology in Hyderabad. And I also invite our today's presenter, that is Dr. Rashna Goyal. She's doing her fellowship at Urban Newborn Care, Ahmedabad. Today's our topic is, as Sheila Madam said, that it's a very thing which we practice in our country, but it's been practiced now all over the world. And they have cited these from our country's research. So that's a very pride for our country, that fully exclusive enteral fluids versus gradual feeding, that is feed one trial. It's a very superior trial, open label, parallel, and a multi-centric RCT. I request Rachna to start the thing, and I request Aparna Madam, most welcome, and we are very privileged to have you as our expert. Welcome, Madam.
Thank you, Dr. Urvi ma'am, for your kind introduction. Thank you to Yogesh Parikh sir, to Sheila Madam, Dr. Bijan Saha sir, who was my senior at AIMS. It is indeed my pleasure to be able to meet so many doyens in the field of neonatology, and NNF Gujarat. My heartfelt thanks to all the members, to my good friend Dr. Biraj for having me over here today. So we'll hand over to Dr. Rachna without any much further delay to begin the presentation of the journal. And we will stop, pause wherever there are discussion points. I kindly request Sheila ma'am and Dr. Bijan sir to also join me for comments, questions, and any discussion points as we move forward. Over to you, Dr. Rachna.
Are my slides visible?
Yeah, now
Yes.
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 Good afternoon, everyone. I'll be presenting the article, Full Exclusive Enteral Feeds from Day 1 versus Gradual Feeding in Preterm Infants, which is an open label, parallel group, multi-center, randomized superiority trial. It was published in the Lancet in 2025. I'm presenting the article under guidance of Dr. Binoy sir. So to summarize, for preterm infants, there is limited nutrition accretion and reserve as they are born preterm. So the third trimester reserves are not present for those infants. So they are at a risk of nutritional compromise. On top of that, there is immature digestion because their digestive enzymes are less functional than the adult levels. Absorption is lesser. Their metabolic pathways are not well developed. Also, there is an increased nutritional demand due to the illness. So most of the preterms in our practice, we see they receive IV fluids with some trophic feeds along with parenteral nutrition, and while gradually the milk feeds are increased. So the risk of IV fluid is they carry the risk of infection, metabolic imbalances. Also, they are poorer in nutrition compared to milk feeds due to limited bioavailability. Whereas we think that starting with exclusive milk feeds earlier might increase the risk of NEC and feed intolerance. So the research question was whether starting the full enteral feeds on day 1 would reduce the length of hospital stay for infants which are born between 30 to 32 plus 6 weeks of gestation and not increase the risk of NEC or other topics. So the study design was, it was an open label study as the treating physician and the parents were not blinded in the study, only the investigators were blinded. It's a parallel group multicentric study. It's a randomized trial and was approved by the East Midlands Derby Research Ethics Committee and funded by the UK National Institute of Health and Care Research. This study was also done in collaboration with BLISS, which is an organization for the families of infants which are born preterm and sick. The participants of the participants are mothers of infants who are born between 30 plus 0 to 32 plus 6 weeks gestation age. The study took place across 46 neonatal units in the UK with enrollment period between 15th October 2019 to 14 July 2024. The infants who enrolled in this study were younger than 3 years of age and who were clinically stable. Excluded participants were infants with congenital anomalies that would make enteral feeding unsafe, SGA with reversed and diastolic flow on the umbilical Doppler, and mothers who had already participated in the study during a previous pregnancy. So randomization in the study, the median age at randomization was 1.7 hours. All the babies were randomized before 3 years of age. Randomization was done using a web-based system, which was maintained by the Nottingham Clinical Trials Group. There was a minimization algorithm with a random element to balance the factors like the place of birth or treatment, the NICU, whether it was a twins or a single pregnancy, gestation age, SG, or whether IV fluids were started before randomization. So the mothers were assigned to groups so that the twins would belong to the same group, which was preferred by the parents. And consent was taken, oral consent followed by a written informed consent or directly a written informed consent of the mothers. And investigators and data analysts were masked. So the intervention and control. So all the mothers were divided into two groups, that is a full milk feeding group and a gradual milk feeding. The full milk feeding group, all the infants received around 60 to 80 ml per kg per day of milk feeds on day 1. Whereas for the gradual milk feeding group, maximum 30 ml per kg per day of milk feed was initiated on day 1 along with IV fluid or parenteral nutrition. So the other things like the feeding intervals, how to increment the feed, the type of milk which was used for supplementing the mother's milk on the initial days, definition of feed intolerance, when to stop or interrupt milk feeding were as per the clinician discretion. And full enteral feeds here were defined as at least 140 ml per kg per day, which was sustained for at least 3 consecutive days. And adherence to allocation was defined as at least 24 hours or less IV fluid or parenteral nutrition from birth till reaching full enteral feeds for full milk group. And if babies had received more than 24 hours of IV fluid or parenteral nutrition, they were in the gradual feeding group. So the primary outcome analyzed here is the length of the hospital stay, and secondary outcomes are survival to discharge, incidence of NEC, incidence of late onset sepsis, hypoglycemia, or the breastfeeding rates at discharge. Since the discharge criteria were subject to different unit policies for discharge, they also took into account an objective discharge criteria, which had 3 important parameters. One is weight of at least 1,700 grams, ability to take at least 1 full suck feed, which was assessed as adequate, and not receiving any additional nutritional support for 24 hours. So the sample size calculation is based on the previous studies. The length of the hospital stay was around 20 to 40 days with a standard deviation of 9 to 16. They used a standard deviation of 13 and estimated the sample size, keeping a group difference of mean of 2 days with 90% power and 5% two-sided significance. Since there were a lot of twins and triplet pregnancy, they added a 15% inflation to the sample size, and 2% for the missing infants, and 2% extra inflation was added. Statistical analysis, baseline demographic and clinical characteristics were described as counts and percentages for categorical variables, and means and SDs, or median and upper and lower quartile for continuous variable. Intention to treat analysis was done except for those who withdrew consent, and infants who had died before discharge were not included in the analysis of primary outcome, but they were included for analysis of the other outcomes. And for continuous outcomes, linear models, binary outcome logistic models, and time to event outcome Cox regression models were used. Also, an exploratory non-randomized analysis was done to see the difference between infants who had received a donor human milk versus those who have received a formula milk as supplement to mother's milk. So the trial profile, 8,366 potential eligible newborns. So these mothers were approached antenatally who were expected to deliver between 30 to 32 plus 6 weeks, and consent was taken. Out of that, after delivery, some new mothers who were delivered, which were not expected to deliver but had delivered infants between 30 to 32 plus 6 weeks, were added to the trial. Based on the inclusion and exclusion criteria, plus those who gave consent, few infants were transferred to different hospitals, some went missing. So at the end, there were 2088 infants who were randomized, 1047 in the full milk feeding group and 1041 in the gradual feeding group. Out of them, for 18 babies, primary outcomes were not available in both the groups, which is similar. So 13 had withdrawn consent, 4 died before discharge, and 1 was missing in both the groups. The baseline characteristics of both the groups, the gestation age, the mean gestational age in both the groups was 31.7 weeks. The mean birth weight was around 1.6 kgs. SGA babies were similar in both the groups, that is birth weight less than the 10th centile. And in this type of respiratory, in this the birth weight less than 1 kg, we can see that there are very few number of babies who are less than 1 kg. Then the infants who are receiving respiratory support are also similar in both the groups. The number of babies on mechanical ventilation are very less, but they are similar and comparable on both the groups. All the other baseline characteristics like multiple pregnancy, the ethnicity, mother's age, mothers who had received antenatal steroids or Maxulf were also comparable in both the groups. So the amniotic membranes that had ruptured more than 24 hours of birth, the number is also again similar in both the groups. So this is the adherence to treatment allocation or reasons for non-adherence. So the babies who are classified into full milk group and gradual feeding group, we can see the babies who are classified as adherent to the treatment in the full milk group is 61.5%, whereas in the gradual feeding group it is 91%. So we can see there were a lot of fallouts in the group which had full milk from day one. So the reasons have been given down as not tolerating feed, had hypoglycemia, they needed escalation of respiratory support, or there were abdominal concerns like suspected NEC or other clinical deteriorations. But there is a significant difference in the number of fallouts in the full milk group and the gradual feeding group. So the results of the study, the length of the
Dr.
hospital.
Rachna,
Yes, ma'am.
just before you start with the results column, if I could just stop you here.
Yes,
So
ma'am.
what are your observations? Can you go back to the slide on the study flow?
Sorry, ma'am.
Can you go back to the slide on the flow, the study flow? Yeah,
Yes,
trial profile.
yes,
Yeah,
ma'am.
yeah.
Yes, ma'am.
So yeah, just pause here. So there were, I think, close to 8,300 eligible mothers. So any
Yes.
comment here on the huge number of mothers who were either approached for consent or who were otherwise eligible for participation, but were not eventually a part of the study. So what is your comment on that? Is that something that you normally expect?
Uh, there are 5, 6, 8, 7 infants who had not given the consent. Among that, there were 2,000, around 2,700, which had not been even approached by the
Yeah.
research team. 562 were not eligible because of either a congenital anomaly or a small gestation age with reversed end diastolic flow. 11 infants had mothers who had already participated in the trial previously, and 5 infants had mothers who were not able to give an informed consent. And then,
Yeah, that's okay. I mean, we
Hmm.
can read the different reasons for the why those mothers could not become a part of the study.
Hmm.
So, but overall, if you look at the number, they had approached 8,366 eligible preterm mothers between 30 plus 0 to 32 plus 6 weeks gestational age, which was
Hmm.
the sort of eligibility gestational age for the study.
Hmm.
But they only ended up taking, 2,244 mothers had
Hmm.
actually given consent. So almost more than two-thirds mothers did not participate in the study. That's a huge
Hmm.
proportion of exclusions. In the sense, these are not post-randomization exclusions, which is more serious. This was
Yes.
even before randomization. However, do you think it can kind of influence the results of your study?
Hmm. Uh, yes, ma'am, because it will not represent the entire population which we were looking into, because out of the people
Exactly.
eligible, only 2/3 had participated. So it may cause a variation in the results.
Exactly. So if you actually look at the reasons, a large number, 2,719 infants were not even approached by the study team. So we do not know why they were not able to approach them. Is it because of certain specific demographic factors that made these mothers, more difficult to be enrolled into the study? We do not know whether they that could have had any bearing on our final findings. So
Yes.
that's a very huge dropout. I just wanted to make a mention of that. Of course, after their randomization, I think the number of exclusions. If you can go to the next slide.
Yes,
Uh,
ma'am.
Only around 18 infants in each of the groups. They have mentioned that the primary outcome for some reason was not available. So the post
Yes.
randomization exclusions were reasonably small.
Hmm.
But still, we do not know why around 5,000 mothers did not
Hmm.
take part in the study and whether that could have had any impact. And any comment on whether they should have randomized infants after birth versus randomizing mothers in a study like this, which compares, two different types of feeding regimes?
They could have randomized the infants even after birth, but since they were in collaboration with the parental team, the parents wished that both their babies stayed in one group. So that is why they randomized the mothers before the gestation, so that twins or triplets would fall into the same group. Uh,
Yeah, I mean, there are two ways of looking at it because this study at least, it involved a postnatal intervention. There was no antenatal
hmm,
intervention per se. It might have been technically possible to, randomize preterm infants after they had been delivered, because
hmm,
even in the early day one enteral feeding arm, the first feed would have been given at say 2 hours or 3 hours of life. So it was technically possible for the preterm newborn to have been randomized into the full feeding group or into the standard feeding group. They still would have had time to open the envelope and look into the randomization sequence. But if you look at the discussion, they have given some reasons for the randomization at the level of mothers, because they were anticipating that these babies would need exclusive mothers feeding right from the day one. So it was a good thought that they thought, why not, randomize at the level of mothers. But more so when you look at twins, if you had done a postnatal randomization, you might have ended up randomizing one of twin to either arm, and that might have been, yes, somewhat challenging for the parents. So I would hand over now to Dr. Bijan sir or Sheila ma'am if they have any comments. A lot of exclusions pre-randomization and timing of randomization was antenatal.
Thank you, Aparna, for raising an important question. So let me tell one thing. Randomizing or taking consent in our country is not difficult. But in the West, if you see not only this study may be a huge number. The women are empowered. Parents are more empowered than anybody in this country. So what happens, even in normal study, even there will be a lot of refusal. And because once they wanted to take the consent, definitely they have told, so this is the standard of care, but we want to conduct a study comparing with the standard of care with this. So when parents will know that already there is a standard of care, then why you will be given another arm? So many times they will refuse. Second important thing, why antenatal? Ideally, antenatal consent is a must, but in our country, and the second important thing, in their country, delivery room is treated as an ICU. 4 or 5 people will be there in the delivery room, right from the surfactant, first dose of surfactant, then IV line, feeding, everything will be started in the delivery point. And consent is not taken in the antenatal period, then it will be difficult. So their mode of delivery is little bit different. They are, even once the baby is stabilized in the delivery point, then the baby is kept in the NICU just a stable baby, which doesn't happen in our case. Maybe these are the reasons. One is the parental education. That education level is very high. Even in normal, that's why when we submit some RCT, even there is less refusal, then they question how it can be possible. There is so many less refusal. I think these are the few. And another thing, they have given that reason why there was non-adherence to protocol. I think these are the few things that has kept my that is in my mind, because in their country you cannot take consent like that. So you have to tell them adequate time. They will think, and after that. So perhaps this is the antenatal counseling and antenatal consent is more important than postnatal. Because parents will not agree.
Also, the calculation of sample size. If you can go to that slide, Dr. Rachna.
Yes.
I think 2 slides after this. No? You
Yes.
can go to the slide where you spoke about the sample size calculation. So the baseline characteristics, it was pretty straightforward. They have shown that the mean gestational age or the mean birth weight of enrolled infants was similar in both the groups. You are particularly worried about, SGA infants with Doppler abnormalities. Those were also comparable. Now here, for the sample size calculation, do you have any comment on the outcome, the variable that they used for sample size calculation? They've used the duration of hospital stay. Now, ideally, for calculating sample size, the type of outcome that you would generally want is a hard outcome, an outcome which is non-ambiguous. For example, if I say proportion of babies who died or proportion of babies who developed BPD, it's very straightforward because you have standard definitions to define these outcomes. So why do you think they took hospital stay as the outcome?
They basically, along with this, they also wanted to study the cost of healthcare which was involved in taking care of these babies, along with parental satisfaction which was present on both the groups. So parents were more worried about how soon the baby can be discharged from the hospital, probably why they took the length of the hospital stay as the primary outcome. To minimize the errors in different discharge policies of all center, they have made an objective discharge criteria outcome, which they have also studied so that it can be uniformized along various hospitals.
So agree with you, Rachna. The duration of hospital stay is a very important outcome in terms of parental satisfaction, in terms of cost, especially in a private healthcare setup where parents have to pay out of pocket. But if you look at the objectivity of the outcome, you can argue because I can have a discharge criteria in my unit. You may have a slightly different discharge criteria. I might say 1500 grams. Bijan sir might say 1400 grams or 33 weeks. You might say 1700 grams. So it's very clinician dependent or unit dependent. But in order to remove those that variability, yes, as you said, they have also looked at the duration to reach the discharge criteria, which was predefined. Fine. But if you were to actually kind of look at the study from the clinician angle, when you look at this kind of comparison, what is your most important outcome of interest? Full feeds versus gradual escalation of feeds.
Uh,
NEC, right?
yes, ma'am.
Obviously, anybody would say as an adverse effect, we are worried about NEC. But probably if you're taken NEC as an outcome, that being so rare, more than 30 weeks, the incidence of NEC is so uncommon. So it might be 0.5 to 1% in each arm. And in order to demonstrate a difference in NEC, you might need a huge sample size. But
Yes.
if you had looked at other surrogate outcomes, maybe things like the duration of intravenous fluids, the duration of parenteral nutrition, or the number of central lines used, or the incidence of late onset sepsis, these could have also been used as some other meaningful outcomes because you anticipate that in the early enteral feeding arm, the use of central lines, use of peripheral lines, duration of IV, duration of PN, all this could have come down. So again, open to comments. Bijan sir, Sheila ma'am.
Thank you, Aparna, for raising another important issues in sample size calculation. Apart from what you have said, that is correct, that once you actually try to select our primary outcome, it should be a meaningful clinical outcome. Second important thing, from the statistical point of view, if it is a continuous outcome data, the sample size usually comes less. If it is a proportion, definitely it will be huge number of sample. That is why when there is a possibility, you can take continuous data as a primary outcome. Many people take the primary, let me give an example. Suppose I want to see the hemoglobin level in between the card umbilical cord milking versus intercord clamping. I can take hematocrit, I can take hemoglobin also. If I take hematocrit and you want to take a difference of 1%, that will more than 10 times the sample will be there. That is one reason. That's why you will find nowadays many studies, because if it was a proportion rather than days, then you would have a huge sample. That is one. The most clinically important outcome, and always the statistician and the researcher tries to see whether the outcome is a continuous outcome or not. Continuous data is there. If it is continuous, that's why they have taken SD and the days. So then the sample size definitely comes a little bit on the lower side. Otherwise, it will be 7,000, 8,000. So proportion. That's why if you can avoid proportion, always avoid proportion. I think that is another reason, because if you see there are 46 units in 5 years, they collected a patient of 2,000. Now you divide 2088 divided by 46. How many samples they have taken from one unit? It is very, very less. So when your sample is less, delivery is less, population is less, then you have to find out some other way. So, but definitely outcome should always be, we should consider once we are actually considering what is the primary outcome. I think that is what I wanted to say. That is there because if you take hematocrit, there is in place of hemoglobin, sample size will differ. That's why is always now in now many studies have seen BPD. What is the duration of BPD? Rather than proportion of infants having BPD. If you go for proportion, then definitely it will increase the sample size. And another important thing here, they have taken into consideration of their twins also. Now, in most of the studies, they are taking separate sample size calculation for gestations. So they are actually taking an inflation point by 10% or 15% like that. So that is there. Now, so because in their population also there is some number of twin population is there. So I think they have taken the right decision. That is what the researchers do when they are calculating sample size. I think she can carry on. Any other comment?
I think she can carry on.
My audio has been an issue. I'll come out later. Probably we can.
Okay, ma'am.
Another thing which I
Hello, madam.
on
There is some issues in your.
discharge. Have they
I think Rachna, you can continue. Dr. Rachna.
Yes,
Yeah,
ma'am.
madam, you may drop the question in the chat box because your voice is not audible. There's, I think, network
Okay.
issue. It's cracking. Your voice is cracking.
Okay, I'll do that.
Yeah. Yeah, Dr. Rachna, you may continue.
Yes, ma'am. I will now discuss the results. So the primary outcome, that was the length of the hospital stay. In the full milk group, it was 32.4 days, whereas in the gradual feeding group, it was 32.1, which was almost similar, did not make any significant difference. This is a Kaplan-Meier curve, which they have compared the time to stop the IV fluids in both the groups and also time to hospital discharge. The time to stopping the IV fluid, we can see that the full milk group babies were able to stop the IV fluid much earlier. So at any point, the 68% babies in the gradual feeding group were more likely to have continued IV fluid than the full milk group, and which was statistically significant, the difference to stop the IV fluids. Whereas time to hospital discharge did not make any significant difference in both the groups. Duration of IV fluids or parental nutrition along here also we can see that the duration of IV fluid and the parental nutrition received by babies in the full milk group was much lesser compared to those by the gradual feeding group. The volume of milk which was received on day 2, 3, and 4, which is significantly higher volumes received by the full milk group compared to the gradual feeding group. Here we can see that as the days are advancing, the difference between the two groups, they have been catching up on that. But still there is a difference between the volume of milk received among both the groups. So the infants in the full milk group had reached full milk feeds, that was 140 ml per kg per day for 3 days at a median of 14 hours. Compared with 99 hours in the gradual feeding group. So here are the other analysis, which is survival to discharge, incidence of sepsis, NEC, which are not significant. They did not make any difference in both the groups. Any breastfeeding rates at discharge were similar. Even survival to 6 weeks, the data they have collected as follow-up on 6 weeks, which is also similar, not making any statistically significant difference in both the groups. Even the mother's breast milk fed in both the groups have been similar, although the percentage of infants receiving mother's breast milk is lesser, that is around 50% in both the groups. The time to objective discharge criteria is also similar in both the groups, not statistically significant, so it did not make a difference even in reaching the objective discharge criteria. The time to full enteral feed, as we have already seen, was much lesser in the full milk group compared to the gradual feeding group. Now they have compared the days of parental nutrition which was received by babies in both the groups until discharge, which was lesser in the full milk group. Number of central venous lines, time with the central line, peripheral cannulation, number of cannulation, all are lesser in the full milk group compared to the gradual feeding group. But there was no difference in late onset sepsis or incidence of NEC in both the groups. Actually, the number of NEC in full milk group was lesser compared to the gradual feeding group, but it was not statistically significant. This we have already seen. The time to regain the birth weight is also similar in both the groups. They've also compared on the follow-up, the growth has been monitored. So the growth Z-scores corrected weight at discharge was similar in the both groups. Length was similar and the head circumference at discharge have been similar. So they did not find any difference in the outcomes in both the groups with regard to the growth. The parental satisfaction and well-being also similar in both the groups. So the result was basically there is faster time to reach a full enteral feed, lesser days of parental nutrition, lesser number of central line insertion, shorter duration of central line in babies where it was inserted, less number of peripheral cannulation, but there was no effect on incidence of either NEC, late onset sepsis, hypoglycemia, or breastfeeding rates at discharge or on follow-up. They have done a subgroup analysis based on the gestational age. So in the first forest plot, gestational age, they have divided into 30 to 32 plus 6, 31 to 31 plus 6, 32 to 32 plus 6. So here we can see that the 32 to 32 plus 6 weeks, those babies favored the full milk growth, the length of the stay. But of course, these babies would have been better in weight and much more clinically stable, which explains why they favored the full milk group. There was no statistically significant difference in this. Also, when they looked for the same length of stay on the SGA babies, it did not make any significant difference. Late onset sepsis also in various gestational age did not make any statistically significant difference, and also the rate of NEC did not make a difference among both the groups. They had done an exploratory analysis to compare whether donor human milk and preterm formula that was used to supplement the mother's breast milk made any difference on the length of the hospital stay. Here, the result was the mean length of stay for the babies who had received only donor milk in addition to mother's breast milk was 36.3 days, whereas the babies who received preterm formula was 26.8. Which was statistically significant, but this can be explained by the babies who were clinically more stable and had a better birth weight had received formula feeds, whereas the babies who were like lesser birth weight had any and more premature would have received donor milk. So they had done a follow-up for 6 weeks corrected for preterm birth. In the follow-up, as we had already discussed, they've analyzed the growth parameters and the breastfeeding rates at 6 weeks. And they're also doing a trial, continuing the trial follow-up up to 24 months corrected age to assess the neurodevelopmental disability, and the formal health economics evaluation is also under progress. Now I just brief on the other studies which are...
Before
Yes.
1 second, before you go on there, Dr. Rachna.
Yes,
So,
ma'am.
what is your comment on the outcomes of the study? So, we all heard that there was no difference in the primary outcome, which was the length of hospital stay. Neither was there difference in necrotizing enterocolitis, which is very reassuring. But there were some difference in some other secondary outcomes like duration of PN, duration of intravenous fluids, and total number of central line days, etc. Is that something that is attractive to us? Is that something that is still significant to a country like us? So, what is your comment on this?
I mean, a resource-limited country like us, that would make a difference if the babies are on full milk group. There are a lesser number of central venous line insertion, which one is save the cost. Also, it will reduce the risk of infection being introduced to baby. So, the more the invasive lines introduced in the baby, there is always a risk of late onset sepsis. So, in our country, this would make a significant difference in the outcome.
Absolutely. If you had to think of some similar example in other domains of neonatology, you could think of trials like COIN or support trial. So when they compared CPAP versus intubation among extremely preterm infants, less than 28 weeks, less than 27 weeks, most of these studies came out and said there was no difference in the primary outcome, which was usually death or BPD. But when you went back and saw the other outcomes, they did show that starting CPAP in the place of intubation resulted in significant reduction in the need for surfactant or in the need for mechanical ventilation in the first 72 hours. Now, although not the pre-specified primary outcomes, these are important outcomes for us as clinicians. So likewise, in this study, although there was no difference in necrotizing enterocolitis or in the primary outcome of hospital duration of stay, there were significant benefits seen in the form of decrease in the need for intravenous fluids and parenteral nutrition, a very, very huge finding for a low resource setting like ours, a low resource or a low middle income country like ours, where every day of reduction in intravenous fluids, every day of reduction in parenteral lines, or every central line avoided can also have important outcomes. And the other reassuring thing that this study also saw was starting full feeds right from the day one in babies more than 30 weeks did not increase the risk of NEC. Although they said no significant difference in NEC, the more clinically relevant way of looking at it, I would say, is at least it did not increase the risk of necrotizing enterocolitis, and also it did not result in infants going home more on supplemental feeding, because most mothers may not have been able to produce enough breast milk to give 60 to 80 ml per kg of enteral feeding right on the first day, because we all know that on the first 48 hours, 72 hours, mothers would only produce drops of colostrum. So babies must have obviously been on donor human milk and some supplemental preterm formula milk. However, this did not change the exclusive breastfeeding rates at discharge and subsequently at follow-up. So this is also an important reassurance that the study has given, that look, this did not increase the risk of NEC, and it also did not increase the number of infants going home on supplemental feeds, although we started milk for all infants right on day one. But if you see the number of infants who had actually received the full enteral feeding right from the first feed as per the plan, what was the proportion of infants who actually received the intervention?
1047 babies, almost 50%. Okay.
But
yes.
you had some of 37 to 38%. You could not continue
Yes,
with the
ma'am.
protocol.
Yes, ma'am.
Yes.
So 61.5% had actually received the full milk.
Yeah. So a lot of infants could not receive full enteral feeding, as per the plan. Although 1047 were randomized, not all of them received full enteral feeding, and mostly it was for clinician perceived feeding intolerance. Somebody felt the baby's abdomen was distended. There were a lot of pre-feed residuals. There was some suspicion of NEC, or the baby was otherwise becoming clinically unstable, respiratory-wise or hemodynamic-wise. So they wanted to go back on feeding. But these are pragmatic differences that we all will face in day-to-day practice. So the trial actually made it very pragmatic and said, yes, this is how the practices are going to vary. We may plan something, but we may not be able to implement it all the time. So that was a very practically valid point of view from the researchers. They didn't say, yes, this was planned to be full feeding. No matter what, we had to go on to full feeding, or they did not try to control all the ICUs and say, this is how feeding intolerance needs to be managed, which they could have done. They could have brought in a protocol for feeding intolerance management and say, only if these criteria are met, clinicians can stop full feeding. But rather, they gave the liberty to the treating clinicians and said, okay, if you're not comfortable with continuing full feeds, you can go slow, you can withhold, reassess, and go back. But despite all these pragmatic differences, they were still able to demonstrate a significant duration on the mean time to reach full feeding. They reached full feed within 14 hours in the intervention arm, even though it was not from the first feed in every baby, at least 14 hours, still much more lower than 99 hours in the control arm.
And probably their average birth weight was much higher than what probably we see with VLBWs whom we treat with exclusive enteral feeding.
The mean birth weight in both the groups was 1.6 kgs.
Yeah, that's what I'm saying. Probably for us, even our FBNC guidelines and all, more than 1.5, unless until really some factor, we would always go ahead with complete full enteral feeding to start with.
Yes.
Hello.
Yes, sir.
Some of the important points to note from this study. If you see the antenatal steroid coverage, 89.9%. Maxalf, 61.5%, 61, almost 62, 61-62%, which is not the case in our population.
The population, true.
That is one of the important point we have to. If you see any infant, so their antenatal steroid coverage is more than 90%. But one thing is reassuring. Even you start full enteral feed on day one, there was no statistically significant difference, but it can be safely started in day one, even a baby who is born at 31 or 32 weeks of gestation, which we have seen in our studies in our country. So even there is no statistically significant difference, but there is clinical difference. As Aparna has rightly said, that incidence of infection, then NEC. But one important point in their case series, the incidence of NEC was only 0.4% and 0.6%, which may not be the case in our population. It's 0.4 and 0.6%. So that is one important point is the antenatal steroid coverage is so high. So these are the problems like RDS, NEC, time to reach full enteral feed. Everything depends on this antenatal steroid coverage. So having said all these things, because if we start early enteral feed without any intravenous fluid, at least we are giving full calorie. So even in our population, if you start partial food feed and partial fluid, you cannot achieve that 30 or 40 ml, even the half of the calorie what the baby should receive. If you do not give parenteral nutrition, which may not be possible in our country. So when that facilities are limited, and we can, if the breast milk is available, so these babies can be safely started on enteral feed. I think these are the few points what I have understood from this presentation. Not from this presentation. In any Western study, you see that antenatal steroid coverage is 90%, more than 90%. So we have to improve our antenatal steroid coverage. Then whatever problem we are facing, that will also come down. So I think, Rasna, you can carry on.
Yes.
You can carry.
Hmm.
So there are a few other studies we'll just go through. These are mainly Indian studies which were performed. So this is early versus gradual feeding. Here the birth weight was 1,000 to 1,499 grams for infants born between 29 to 33 week of gestation. So 60 infants were randomized within 24 hours of admission. What they noticed was there's a significantly shorter time to reach the full enteral feeds in among both the groups when you gave full enteral feeds on day one. This is another study which was done on babies 28 to 32 plus 6 weeks of gestation. 102 infants were enrolled in the study and they were randomized in the first 36 hours. So they noticed their increased number of full enteral feeding days as a total number of days in which the baby was fully fed enterally. Also, the fat-free mass for age on the postnatal day 14 and the length for age on at the time of hospital discharge made a significant difference when the babies were given enteral nutrition, and the hospital cost also differed between both the groups. There's another study which was performed between 30 to 33 plus 6 weeks, where the babies in the treatment group received complete enteral feeding, that is 60 to 80 ml per kg per day. And the primary outcome was time to reach full enteral feed. So the infants in the early enteral feeding group achieved full feed sooner and received lesser hours of parental nutrition and also had shorter hospital days. This is a Cochrane review which was done for 14 trials and included around 4,000 infants, and they compared slow advancement of feeds compared to faster advancement that did not have any effect on NEC or any all-cause mortality. In fact, they noticed that the slow advancement group might have slightly increased feed intolerance, but it was a low certainty evidence. And there was a slight increase in the risk of invasive infection, again a low certainty evidence. There's another study which was done on infants 1200 to 1500 gram weight, irrespective of the gestation age. And in this study, there was no IV fluids was given as supplement to the babies in the full enteral feeding group. So 23 babies were randomized in each group, that is 46 babies in total. And the full milk group could regain the birth weight earlier. And the duration of hospital stay was lower. Also, no NEC was detected in either groups. There's another study, which is an Indian study, which enrolled 208 neonates between 28 to 34 weeks. And this was a phase trial in which, in the first phase, they did the standard practice of initial IV fluid along with the trophic feeds and gradually advancing. The second phase was implementation of early total enteral feed, where the infants received complete enteral feeding as per the fluid requirement on day one. And the third phase was just done to assess the sustainability of the change in the practice. So in this, they noticed that the incidence of feed intolerance was comparable between both the groups. There was a marked reduction in the incidence of NEC when the babies were given full milk feeding since day one, and also a significant decrease in sepsis, duration of parenteral nutrition and antibiotic therapy, and also hospital stay, and mortality was comparable in both the groups. So now this is a consort checklist for this RCT. So identification as a randomized trial, yes, they have given a structured summary of the trial design, method, results, and the conclusion. The name of the registry with identification number was given. The trial protocol and statistical analysis plan is available for access. The how they had collected the data and other materials is also available. Sources of funding and the financial conflict of interest are mentioned, which was none. Background and rationale was explained, and specific objectives were also explained. So the details of the involvement, conduct, and reporting of the trial has been explained. The study design has been explained well. Important changes to the trial after it commenced were also specified as non-adherence to the allocated group. The settings, the hospitals which were included in the trial were mentioned. Eligibility criteria have been clearly defined. So the sites and individual which were delivering the intervention was not applicable, and they had also accounted for the missed babies have been mentioned in the group. Their pre-specified primary and secondary outcomes have been mentioned in the study, and any harm, that is feed intolerance and the late onset sepsis. There are a few criteria which were there, but at the end it was on the clinician's discretion, which was also mentioned in the study. The sample size calculation and the assumptions which were supporting the sample size have been mentioned in the study. The analysis and the stopping guidelines have been mentioned as in on a discretion of the clinician. The randomization method was mentioned, which was a web-based system with minimization and along with a random element to balance both the groups with the baseline characteristics. The person who had enrolled and who were participating were not blinded, but they did not have access to the random allocation sequence. The blinding was mentioned, that is, the clinician and the parents were not blinded, whereas the investigator and the data analyst were blinded. Statistical methods had been clearly described. Definition of who can be included in the analysis and who was not included have been clearly mentioned in the study. The missing data is also how it was handled is mentioned in the study, that they had done an intention to treat analysis. So, and the other analysis, that is a subgroup and the exploratory analysis have been given. For each group, again, the intention to treat analysis were mentioned, and the primary outcome, that is the babies who died before the discharge, were not included in the primary outcome. So that has been mentioned in the group. The period of recruitment and the follow-up for the outcomes has also been mentioned in the study. And who has the intervention and the comparator was clearly mentioned in the study. The baseline demographic and clinical characteristics have been well described. For each primary and secondary outcome, they have described the number of participants who took place and how the flow of the trial was have been clearly given in the group. And, yes, interpretation of the result and balancing had been done well. So this was the consort checklist. Now the strengths of the study is that one is it included a large population. However, as we saw that only two from whoever were eligible, a very few number of infants could be included in the study. It was a multicentric study. Randomization was done on day one with a mean age at randomization was only 1.7 hours. That is very early randomization into two groups. They'd also studied the effect on survival, NEC, sepsis, breastfeeding at discharge, and also parental satisfaction. Follow-up study was also done at 6 weeks for the growth monitoring, breastfeeding rates, and parental satisfaction, and also a 24-month study to check the neurodevelopmental disability is ongoing at present, and they are also planning to do a health economics evaluation after the end of the study. So the limitation of this study would be it was an open label study, there was no blinding done for the clinician. So the clinician would be aware of which group the baby belongs, which might have had an effect on the performance bias as whether to stop the full milk feeding and shift the baby to gradual feeding in case of any feed intolerance was left on the clinician discretion. The length of the stay was again influenced by unit discharge policies, which they had tried to overcome by the objective criteria. The study was restricted only to very stable infants between 30 to 32 plus 6 weeks. So we cannot extrapolate this result to some higher risk newborns. There was partial non-adherence to the full milk protocol. As we saw, there were only 61.5 babies actually adhered to the actual protocol, where the rest had fallout, mainly because of clinicians' discretion. So it was a pragmatic study, non-standardized feeding practices based on different units. And to actually account for NEC, which was the incidence was very less, so the study would have been underpowered to actually take into account that. And long-term neurodevelopment data is still awaited for this study. So, implication could be the feeding protocols for stable infants which are born after 30 weeks. We could actually include them in the full milk feeds from birth, as a main factor is it does not make any increase in incidence of NEC. So in a resource limited settings like us, we could actually take the babies for on full milk feeds.
Thank you so much, Dr. Rachna. I think this study is a sort of a valuable reconfirmation that full enteral feeding is possible without increasing the risk of NEC in high income settings. And this study comes from a multicentric background from the UK and Scotland. But as you already said, there have been number of Indian studies that have put this already demonstrated that this is possible. And some of them have included somewhat smaller infants also, right from 1,000 grams upwards, like the study from Lady Harding that you showed. They have actually shown that full enteral feeding right from the first day is possible right from 28 weeks and right from 1,000 grams in clinically stable infants who do not have Doppler abnormalities. So I think India is probably in terms of this particular, practice is one step ahead of the Western NICUs. But it is good to get this confirmation also from the Western NICUs, given that they are extremely cautious about NEC and probably may not have the same rates of breast milk feeding. And it is also, really appreciate you for putting in the consort checklist and for doing a complete critical appraisal of the study, looking into all the aspects of a typical randomized controlled trial. Of course, this study was a nicely designed study, a well-conducted study, had its own bunch of strengths, including a robust protocol. They also had pragmatic choices that were left to the clinicians, wherein a decision to stop feeding based on signs of feeding intolerance could be taken at the level of the individual unit. And as already discussed, the other strength was that they had started the process of taking consent right from the antenatal phase. Probably the very few limitations were a large number of exclusions of eligible infants who could have otherwise come into the study for various reasons, including inability of the study team to approach for consent and not able to get consent, etc., which were again some practical limitations most big studies can have. And the choice of taking hospital stay vis-a-vis other quantitative or numerical outcomes like duration of intravenous fluids or duration of parental nutrition days is something that we can debate. But overall, this was a study, RCT, from a high income setting, from a high resource setup, a multicentric study, could not be blinded. It was open label, but still it was very robustly designed and well executed study that has reconfirmed that full enteral feeding with enteral feeding started from day one in infants more than 30 weeks is possible without increasing the risk of necrotizing enterocolitis, and can provide some other secondary gains or benefits like reduction in the number of intravenous days and parental nutrition days and the number of central lines and the number of peripheral IV lines that are required. Already something that we know very well from, I think, Indian literature, but again comes as a confirmation from the European subcontinent. Thank you, Dr. Rachna, for your nice presentation, and I'll hand over to the other experts for their comments.
Yes, Rachna, nicely presented. Am I audible?
Yes.
Yes,
Yes,
madam.
Yeah. And one more thing, yes, probably as I commented earlier also, they had much larger birth weight babies compared to ours, because ours always are more number of SGAs. They had well covered with antenatal steroids and Magself, as Dr. Bijan put it earlier also. But even without this in our setup, as many of our units, as probably MOM and PDHM being available to many of our center, we have also almost have a good evidence that we should be using early exclusive. And as Aparna told, probably a large cohort from Western country also confirming. But one thing, theirs was probably less than 50% of MOM and PDHM. That's what I exactly could not get the number of percentage of babies who were exclusively fed MOM and PDHM and not formula. Probably most of our centers, we are able to do that. So it would be a good thing for us also to probably think of a more document evidences from our units also, that even SGAs, because most of the SGA, another thing what has been happening is we don't have Doppler studies when we are getting them from periphery. Also many ultrasound and antenatal, this would not be there except institutions. So my public hospital experience many times told me that we had to go, even with SGA, not be too restrictive in our enteral feeding policy. I think Aparna and Dr. Vijan can also add to it that with our SGA also, would you be too strict in enteral feeding policies when you do not have Doppler studies available to you?
Thank you, madam. Not at all.
Yeah, that's what I would just.
Not at all. Because in our, if you see 20 to 30% of our infants will have SGA infants.
Yes.
But all SGA infants will not have feed intolerance or feeding issues. More than 80% of these babies, if you start early enteral feed, especially the mom or PDSM, they will not have any issues. Second important thing is because madam is running a comprehensive lactation management center, we are also running a CLMC here. And most of our babies who are less than 32 weeks or less than 1500 grams, and mothers are not able to give the full amount of milk, we are giving PDHM. And then you will agree with me, once if you give mom or PDHM, the incidence of NEC will definitely decline to a significant extent, even it HGA, whatever it is. I still remember during my fellowship days, my DM days at AIMS, Dr. Vikap also used to tell, give feed will happen, there will be some abdominal distension, even there is feed, we will stop it. But out of that, many of these infants will actually tolerate feed. Even also in this study, 61% of the infants were tolerating feeds from day one itself. That means more than 50% babies in any place. If you start, you can treat these infants or manage the infants with enteral feed only. So if you can manage more than 50% of the infants with enteral feed only, then what is the problem? We should use it in the list of the one or, I think in our country, not more than 5-10% infants will have some feeding intolerance, especially because nowadays more and more non-invasive ventilation we are using. Either non-invasive positive pressure ventilation or CPAP. And all of you will agree with me, here the some amount of feed intolerance will be there because a lot of air will go inside the abdomen, stomach because of non-synchronized, non-invasive positive pressure ventilation. So that also we can tackle. So if we are very careful, if we use early enteral feed, you can increase the coverage of antenatal steroid, you can use other mother's own milk or PDSM. Definitely most of the infants, more than 90% of the infants can be managed with this early enteral feed from day one itself. I think that is one of the things, because once if we start IV fluid and slowly you advance the feed, it takes around almost 5 days. If you start even 20 to 30 ml feed today, then to reach 140 ml per kg per day, you will need around 7 days. That means you are saving 7 days if you start feed on day one itself. Not only 7 days, if you start and IV fluid, definitely the chance of infection, everything will be high. Thank you very much. Another thing I just wanted to add, in any journal club, apart from that, whatever you have said, that consort checklist, there is a checklist for critical appraisal skill program, the CASP checklist. I think our students should use CASP checklist at the end. Critical appraisal skill program, CASP. There is different skill program for RCT and observational studies also. And that could have been added. That is
yes. Critical appraisal list.
the CAPS checklist. Thank you, Rasna. Thank you, Aparna, for giving your expert comment, and thank you, madam. And
Yeah,
once
madam.
again, thank you all the organizer for inviting me and to be a part of this journal club.
Rachna, please stop sharing your screen, Rachna.
Thank you, Dr. Rachna. Excellent presentation, compilation, analysis. Thank you, Dr. Aparna ma'am, for being an expert, Sheila madam and Bijan sir. I hand over to Dr. Biraj and Dr. Praful.
Yeah, thank you, Dr. Bijan sir, and thank you, Sheila madam, for accepting the invitation as a guest. Dr. Aparna, thank you very much for the very best critic. Dr. Rachna, the very nice presentation. Dr. Praful, thank you for running the show, and thank you, Dr. Urvi, for coordinating everything. Thank you, Clarinet, and thank you, Yogesh sir. So, thank you everyone who have joined the presentation and today's Pathshala session on behalf of Gujarat NNF. See you all again, same day next Wednesday at 3:30 p.m. for Neo Grand Rounds, where we are going to discuss typical gray zones of the neonatology on case-based learning, real cases, real dilemma, and real learning at the same time. And the presentations for this the recording for this today's sessions will be available on our YouTube channel. And for getting a further update, kindly follow us our WhatsApp channel. And thank you all. Thank you, Clarinet. Over to you, Clarinet.
So thank you so much everyone for joining this session. Clarinet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much.
Thank you. Thank you.
Thank you. Thank you.
Thank you so
Thank
much.
you.